Welcome to the She Found Motherhood podcast. We are doctors Sarah and Alicia, maternity physicians and moms who have been through it all. We want to empower you with knowledge so you can have the best pregnancy, birth, and postpartum experience you can.
She Found Health and She Found Motherhood is meant for general medical information only. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. This information does not apply to every situation. If you have questions or if you've received different advice, please contact your healthcare provider. Always seek the advice of your physician or another qualified health provider with any questions you may have regarding a medical condition. The views expressed by She Found Health and She Found Motherhood and our guests are not representative of any of the institutions with which we are affiliated. Some of our podcast episodes are sponsored so that we can keep getting great info out there to you, our listeners. We only partner with companies that we truly believe in. Some of our links and suggestions may be affiliates, and we would appreciate you using them to help fund this important work. Now let's get to it. We are lucky enough to have Dr. Megan O'Connell here with us today to review pain management in labor. Megan, welcome. Tell us a little bit about yourself.
Thanks, Alicia. Happy to come and chat today. I'm an anesthesiologist here in Victoria, and one of my roles is to help women during labor and delivery, both vaginal and cesarean section, who are needing help managing the pain they are experiencing. I'm also a bit of an expert on the receiving side as well, as I have 3 kids of my own.
Wow, brave woman. So why don't we start by talking about pain in labor? This is a really challenging one to discuss, as it is so different for each woman. And so we have no idea what we are going to experience going into labor, even from one pregnancy to the next.
That is so true. I read this quote: "The way pain is experienced is a reflection of the individual's emotional, motivational, cognitive, social, and cultural circumstances." What this means is that everyone experiences pain differently, based on so many things. It can even change day to day, if you're in a good or bad mood, excited or scared.
Exactly. Some women have pain only during contractions. Some women have intermittent low back pain during contractions. Some have constant low back discomfort and their contractions on top of that.
That back pain contraction pain is caused by one set of nerves, and the pain that in the perineum or vulvar area with actual delivery is caused by another set of nerves that come out a bit lower down your back.
This is important as we can focus on one or the other sometimes with our pain management strategies.
The 2 main influences on women's ability to cope with labor pain are 1, continuous individualized support during labor. This could be a supportive partner or a friend or a professionally trained doula. And 2, acceptance that some pain is necessary to birth your baby.
Yes, these are both incredibly powerful. When we have expectations of what something will look like and it's consistent with this, we are much more able to cope. So these are both what we would call non-pharmacological or non-medicine options. Are there other non-pharmacological options?
There sure are. These include breathing techniques, distraction with music or talking, acupressure, warm showers, baths, positional changes, and more. Many of these techniques can help, especially during the early parts of labor, and for some women are sufficient to get them through the entire process.
So if those techniques aren't quite cutting it, what else can women in Victoria access to help relieve the pain of labor?
One option is nitrous oxide, otherwise known as laughing gas. This is inhaled by a mouthpiece or a mask that the mum holds during contractions. It takes about 50 seconds to start working, so we suggest that women start breathing the gas as soon as they feel a contraction starting, or even better, before it starts. Women then stop breathing the gas just after the peak of the contraction as it is starting to decrease in intensity. This works for many, but not all women. It's considered safe for both mum and baby. Some of the side effects of this are nausea, lightheadedness, and dizziness.
So I've had women have great success with this, especially during the transition to be fully dilated. If they have made it to that point without an epidural, what are other medications that we can offer?
We have 2 different types of opioid medications that we can offer to women. The first is morphine, which is given as a shot usually in the bum. It decreases labor pain, but it doesn't take it away completely. It lasts for about 4 hours. The common side effects of this are drowsiness, nausea, vomiting, itchiness, and slowing down of your breathing. It does cross the placenta to baby, so the timing of the dose is important.
Yep, that's so true. A couple of things about the side effects. We generally give morphine with Gravol to help with the nausea and the vomiting side effect. We are also very careful about the timing of the shot of morphine. So we would prefer it to be out of your system by the time you deliver your baby. So we tend to try not to give the shot if we expect you to deliver within the next 4 hours.
Right, so if you're closer to delivery, we could offer you the other option called fentanyl. This is given through the IV, or intravenous. It works more quickly and it doesn't last as long, about 45 minutes, so it's safer to give closer to delivery. It does still cause respiratory depression in baby if baby comes out sooner. This can be managed by stimulation of the baby after delivery, and if needed, a shot for baby to block the medication from working.
So true. Now, what about epidurals?
Well, these are provided by anesthesiologists. Victoria has a dedicated OB anesthesiologist on 24 hours a day. They are the most effective form of pain relief in labor. A small plastic tube is left near your nerve roots in the epidural space, and a numbing and pain medication is provided continuously throughout labor and delivery. The epidural is removed after delivery of your baby. This greatly reduces and often eliminates contraction pains. Pressure and discomfort can still be felt during your delivery. Once an epidural is in place, walking is limited to small distances, like between your bed and the bathroom, as it can reduce your sense of balance and affect the strength in your leg.
So with most medical procedures, there are risks and side effects we warn women about prior to doing this. What are these with epidurals?
Well, in terms of risks, epidurals overall are very, very safe. Sometimes they don't work well. 1 in 100 or 1% of women can get a post-dural puncture headache, otherwise known as a spinal headache, and rarely a direct injury to their nerve or infection or bleeding within the epidural space that can happen, causing a nerve injury that could be permanent. Common side effects that can be experienced are a lower blood pressure can make you feel cold, causing you to shiver, and some women get itchy from the medication.
And I know there are certain groups of women that we as delivering docs recommend an epidural to, such as twin vaginal deliveries, women with high blood pressure. Are there any other groups from your perspective that might be appropriate for an earlier epidural?
Definitely. The two groups you mentioned, but also women who have had a challenging time being intubated in a previous surgery before, those who are significantly obese, or women who are attempting a trial of vaginal delivery after a previous cesarean section, or even women with a history of something called malignant hyperthermia. Most would know who they are, as the epidural can also be used for an operative delivery if they need a C-section.
And what about on the other end of the spectrum? Are there any women who should not or can't get an epidural?
Yeah, there are a few rare cases that a woman should not have an epidural, and these women are women who are on blood thinners that they've recently taken, or if they have an infection in the epidural space or area where we would be putting the epidural.
So I often hear from women that they worry that if they get an epidural, they will seem weak, as our bodies are made to deliver babies, and it's a natural process. What are your thoughts on this?
Well, I often say that no one I've ever met would want to have their bone set or their appendix set without some sort of pain relief. A woman has not failed if she requires pain relief during labor. Quite a few studies have actually indicated that most women underestimate the level of pain they might experience during labor. The American College of Obstetricians and Gynecologists say that there's no other circumstance in which it is considered acceptable for an individual to experience severe pain, amenable to safe pain relief, while under physician's care.
Yeah, and it hurts. It's very true.
Yeah, I have to agree with you on that one. It can be pretty intense for some women, or most women.
Most women. There are the silent laborers, but they're few and far between. Hey, Sarah,
Yes, Alicia.
did you have any problems with newborn sleep?
Oh my gosh, I sure did, especially with my first.
Me too. I wish I'd known more about what to expect going into it.
I know, and I wish that I had known to create a sleep plan with my partner.
I know. How can you support each other to get the sleep that you need while supporting your little baby?
Totally.
So guess what, guys? That's why we created the Newborn Sleep 101 course. In this course, we discuss what does newborn sleep look like and how can we help support that sweet little baby to become the best sleeper they can.
While also supporting you and your partner as you navigate this complex, sleep-deprived time.
We talk about how to set up your nursery or your bedroom to optimize both your sleep and your newborn sleeps. And we also start talking about how you can start implementing routines and schedules into your day and your newborn so by the time they're 3 or 4 months, it's well established. Because guess what? That's when they start to really need it.
If you're interested in learning more, head to our website, www.shefoundhealth.com/courses.
We hope that you get better sleep than we did. So what about the myth that epidurals slowed labor down?
So the short answer is not really. A number of studies comparing epidurals to opioids, such as the fentanyl or morphine in the bum shots, have shown that epidurals can actually shorten the length of time that it takes your cervix to dilate, as long as you're in active labor. A large review showed that it only lengthens the time from full dilation to having the baby out by about 5.7 minutes.
What about an increased rate of cesarean section or assisted deliveries, for example, forceps or vacuums, after epidurals?
Well, multiple trials have shown that there is no increased risk of cesarean delivery when comparing women with epidurals to those without epidurals. And when using low-dose epidurals, which we use in Victoria, studies have not been shown to increase the risk of vacuum or forceps deliveries.
Is there a point at which you have missed your window for an epidural?
The answer is no, not unless your baby is about to come out in the next 10 to 15 minutes, as it does take some time to get full effect.
Some women are concerned that medications that they use during labor can affect breastfeeding postpartum. Is there any evidence around this?
So this one's a hard one to study and therefore kind of hard to comment on. There was a study done on women who had had at least one previous baby that they'd breastfed, and in this group there was no difference in breastfeeding rates at 6 weeks or 3 months in women who'd had epidurals versus not. There's minimal or no fetal side effects from the opioids used in epidurals, so we would expect there'd be less interference than morphine or fentanyl given close to delivery on the baby's ability to breastfeed.
So this is all kind of in labor. Now, what if you end up needing a cesarean section?
Well, if you have an epidural, we can use your epidural and top it up. If you don't have an epidural and there's time, you can have something called a spinal anesthetic.
Can you tell us a little bit more about a spinal anesthetic?
Sure, they're really similar to epidurals, but instead of leaving a plastic tube behind, we use a small needle in your back and it puts numbing and pain medicine right in your spinal fluid. It makes you numb from about the chest down. You're so numb that you can't even move your legs. You won't feel anything sharp, but you do feel a touch and pressure. This means that you get to be awake during the operation to meet your baby.
Why would you do a spinal anesthetic instead of a general anesthetic?
Well, a spinal anesthetic is considered to be a bit safer in a pregnant woman than a general anesthetic, for different reasons. Also, minimal medications cross the placenta so the baby is not affected by the drugs like they would be if you had a general anesthetic. Also, as you just mentioned, you get to be awake for the delivery of your baby, and your partner can also be in the room for delivery.
And once the pediatrician is done checking over the baby and your baby's stable, you get to hold your baby while you're still in the OR and we're finishing up with your cesarean section. Are there any risks to a spinal anesthetic?
Well, the risks are the same as they are for an epidural that we talked about a few minutes ago.
And what about side effects?
Common side effect is low blood pressure, and it can make you feel sick to your stomach. Shivering is also common, itchiness from the pain medication as well. These are all treatable side effects, so just let me, the anesthesiologist, know or nurse know about them so we can treat them.
So there's more than one pain management option for the delivery portion of labor that we've not talked about. And frankly, I feel we don't use it enough in Victoria especially. And this is called the pudendal block. This is when we use a little bit of local anesthetic to block the nerve that transmits pain signals from your perineum during the final pushing and delivery phase of labor. This is accomplished by injecting some local anesthetic medication into the vagina around these nerves on either side. It's a bit harder to time and it only lasts about an hour or so and takes a few minutes to kick in. But when it works great. This is generally something that your family doctor or your obstetrician would do. I'm pretty sure that you guys as anesthesiologists don't do this, right?
Definitely not. I'm a waist-up doctor.
Well, that is a lot of information. So how about we summarize? Number 1, in most women, labor and delivery are painful. And this level of pain can be influenced by so many things. And we as women have no idea how we will react or cope with this pain until we're in the middle of it. Number 2, there are non-pharmacological and pharmacological methods of pain management that we should all have access to if we want to help cope with this pain. No woman is weak and no woman has failed if they choose to use any of these methods during her labor or delivery process. Number 3, there is no evidence that shows having an epidural slows down labor or delivery by any appreciable amount of time, nor does an appropriate epidural cause higher cesarean section or assisted delivery rates.
That's right. And we don't know for sure, but we don't think that it affects your ability to breastfeed.
Super. Well, thanks so much for coming on, Megan, and covering that painful topic. I bet you always have a lot of happy people seeing you on the labor and delivery floor.
Well, most of the time they're happy about 15 minutes after I've met them.
Perfect.
Thanks for listening. Make sure to check out our website at www.shefoundhealth.ca and to sign up for our community for weekly bump blasts. Make sure to check us out on Instagram or Facebook at she.found.motherhood and head on over to your favorite podcast app and leave a review and a 5-star rating. If you enjoyed this podcast, take a pic of yourself listening to it and share it on social. Make sure to tag us on it so we know to keep making them.